My first case, broken intercoronary wear. Mr. MC, diabetic, non-hypertensive, smoker, presented with chest pain and diagnosed as acute STMI, thrombolized with STK, and he was presented with cardiogenic shock. ECG ST elevation in anteroseptal leads, and wall motion abnormality was there, 45%. And we have done angiogram. And also we have done the PCI also in the same sitting. This is angiogram, right side there is no lesion. In his left side we can see the lesion in the LAD, and there is also bifurcation lesion with the diagonal. So we go ahead with the PCI, and everything was going fine. He was hemodynamically stable, and we wired the lesion, and we put a wire in the diagonal, pre-dilate the lesion, and we optimize the lesion preparation, and we put the stent also. We put the stent up to the ostium of the LG. And what happened after the stent deployment, we feel that the wire is not coming out. Jailed wire. Jailed wire is not coming out. We try to take out it with a small balloon, but we are not able to negotiate the balloon up to that point. And we also try to do other maneuvers also. On that time, we don't have the microcatheter. We have the plan to go with the microcatheter, and we can go so dilate and take out the wire. Patient is completely okay. He's asymptomatic, and we are in a puzzling situation what to do with this jail wire. So we talk with our colleagues and others. So everybody is saying try to take it out, and if not everything not works, it gently try to remove the wire with a gentle traction. So with keeping the balloon proximally, I try to pull out the gently, and it's broken. And through the stent bush, I found that the broken part is in the coronary, not in the left main. So I decided to leave the wire in such a condition and treat the patient conservatively. And the real problem started how to break the news. So everybody, the party came and I said, yeah, this is very fine. Only I didn't say that I put a wire there. And I shared this thing with my family. She said, you must say it very early. I said, I think I disclosed it before discharge. She said, no, you should immediately tell it. The next day, I called his patient's son, and I disclosed that this happened. Then many calls are now coming from Chittagong, Dhaka, everywhere. There is a broken wire, what to do? So this made me more panic. And I talked with Amit Jamal sir and others. They said, okay, if the flow is all right, if the main vessel is okay, you can leave it there like this. And I go through the literature and found that, yes, this is potentially life-threatening condition. There may be ischemic event, there may be embolic event, even death could be death very rarely. But there are case reports where left alone wire is there, and then nothing happened actually. So we tell the patient everything about what might happen, and we keep in touch with the patient. He was clinically and symptomatically all right, and he was with our follow-up for last 1 year. And after 1 year, we had the plan to do his IVAS with the IVAS training by IPGI. He came, but there are many cases, that's why we couldn't do the IVAS, but we did his check angiogram. And check angiogram after 1 year shows this completely patterned stent and LAG, and the floating wire is hanging like before. So that's a great sight of relief. This time patient is from the hill tracts. He brings some mangoes and the lichus. I couldn't take this before doing his angio. After his angio, I was become free. Okay, this is my next case, Mr. MU, 55 years, diabetic, hypertensive, ex-smoker. Here there's elevation V1 to V4, echo, there is wall motion abnormality. Left main normal, LAG totally occluded, LCX non-dominant, RCA dominant vessels. This is his angio, right side is normal, left side total occlusion, and we take the Fielder XT with the balloon support. We decided to go through PCI. So with the Fielder XT wire and balloon support, I crossed the lesion and started to pre-dilate the lesion. So everything is going fine, and after pre-dilatation, while I trying to pull back the balloon, I have a funny feeling that because balloon marker was there, but something is coming out. So I become puzzled. So what's happened? Balloon marker is there, but things are coming out. I immediately put the assembly forward, and I try to put the balloon marker as distal as possible. Yeah, I was able to possibly keep it in the distal part of the LAG. Yeah. Then what I did, I take another wire. I able to cross that wire beside this, and I take another small balloon distal to this, and I inflate the balloon, and I'm able to take out the whole assembly out. And after removing the whole assembly, I put the stand from the proximal LAG to the covering the lesion. And I post-dilate, optimized my result. And patient was hemodynamically all right. And there's the broken balloon after retrieval. And my last case, when balloon is stuck. This is inferior amide thrombolyzed patient. And after STK, sorry, this is single loop. We do the angio, and we found that there are lesion in the right coronary artery distally. And there is actually two lesions. One is distally and one is the middle part. So we pre-dilate the lesion, and we took actually there is a much healthy part in between. So what we did, we put a distal stand, smaller stand, and proximal one we covered with a big stand, covering there is a minor lesion in the up also. So after the deployment of stand, patient was hemodynamically all right. So we started the post-dilatation, first the distal stand, and then the proximal. And the trouble started when we do the post-dilatation of the proximal stand. We take a 4 balloon, that was a new balloon, but while post-dilated, operator said, the inflation device who is handling, he said there is some funny feelings, he cannot deflate it. Then all the panicky situations appears, patient suddenly deteriorates. We start CPR, we start putting temporary pacemaker, and then nothing works, we couldn't take it out. We try to make another deflate device to take it out. There are many things comes, whether we can other end of the where we can penetrate, but it is so distal the stand, we are afraid to do that. So finally what we did, I made a gentle traction. As you can see, the gentle traction may not be gentle enough, whole thing tried to come out, but finally still settle. We intubate the patient, we put the patient in the ICU, and patient salvage. So my take-home message, challenging complex cases in resource-limited center needs logical approach, perseverance, and teamwork. Complication during PCI may appear anytime like tsunami, but can be managed by teamwork. And complication like tsunami, you need not only logical approach and teamwork, you need all the hardwares available, and you need prompt action. Thank you for your kind attention.